The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Imagine you're caring for a patient who's been short of breath for months. Their echocardiogram shows right heart strain, but they're young with no obvious cardiac disease. You're thinking, what am I missing? In today's episode, we're taking a closer look at pulmonary hypertension, a condition that's often misdiagnosed or missed entirely until it's advanced. It can mimic more common conditions like asthma or heart failure, but its management requires a specific and nuanced approach. To guide us through it, I'm joined by Emily Fedewa, nurse practitioner with the Pulmonary Hypertension Program at UCSF Health. Emily is a part of a multidisciplinary team that cares for some of the most complex pulmonary hypertension patients on the West Coast. Together, we'll explore pathophysiology, clinical presentation, diagnostic workup, and current therapeutic options, including emerging treatments and the critical role of nurse practitioners in chronic disease management. If you've ever felt stumped by unexplained dyspnea or struggled to understand how pulmonary hypertension differs from other cardiopulmonary conditions, this one's for you. Whether you're in cardiology, pulmonary medicine, or primary care, this episode will give you practical insights into one of medicine's more challenging diagnoses. Emily, thank you so much for being here today, and I'm just super excited because you're going to talk to us about pulmonary hypertension, and it's something I don't know anything about.
Great. Well, thanks for having me.
Of course. So can you share a little bit about your journey into nursing?
Yes. Well, I went to school for nursing in New York. I did a combined RN and P program and then took some time off between to work as a nurse and also work my way through the master's since school's expensive. And then I moved to Seattle, where I had my first nurse practitioner job. I started out in primary care, public health.
Okay.
And that was really hard. So after about a year and a half, I went back into cardiology where I had worked as a nurse. And I spent a few years at UW in Seattle working in interventional cardiology and in the CCU, which I loved. And then at the time, my husband and I decided we were going to move to San Francisco just to be closer to family, change things up. And when I came down to interview for some inpatient positions, I don't even think I applied for pulmonary hypertension, but the hiring manager was like, hey, you're coming down. Do you want to interview for this position as well? And I said, sure. And I loved the team. And that's actually ultimately why I accepted the job in pulmonary hypertension.
Wow. Did you know much about pulmonary hypertension when you applied?
I honestly, I knew of pulmonary hypertension, but I really, I did not know. I did not know really what pulmonary hypertension was. I did not know how it was treated. So I had very little understanding of what pulmonary hypertension was, even after working in cardiology for several years.
Yeah. I mean, I echo that same thing. I had no idea really what it was or how it was treated or anything like that until I came to UCSF. And we have a pulmonary hypertension department. And I was like, oh, okay, cool.
Yeah.
Great. Yeah. They can answer all my questions.
Totally. That's how I felt also.
Yeah. As a pulmonary hypertension nurse practitioner, what does your day-to-day look like?
Yeah. So I work in an outpatient adult pulmonary hypertension program. So I see patients both in person, and then we were actually completely in person before the pandemic and then moved to a completely remote model 2020, 2021, when things were really bad. But we are a center of excellence. So we have patients that travel to San Francisco from all over the region. I mean, hours and hours away. In a way, telehealth actually was really wonderful and increased access for our patient population. So even though we now, of course, offer in-person visits, we still have a very heavy telehealth clinic. We're probably at least 50. I haven't looked at the data recently, but we're probably at least 50% remote still. So a lot of telehealth.
Is there, I know I'm kind of skipping around a little bit, but is there a big physical assessment component in your visits? With electrophysiology, we we don't do physical exam unless they're in person because that's just thorough and proper. But there's nothing I'm really looking for that the EKGs and the data can't tell me and their symptoms. Like I can totally treat someone remotely with no physical exam. Is that the same or?
Totally. I mean, I think a physical exam is always helpful, an in-person physical exam, but patients with pulmonary hypertension often have chronic right-sided heart failure. So a volume assessment is definitely indicated and important, but people generally have echoes every 3 to 6 months. And so we can obtain echoes locally wherever they are and then request the report and images. And then we do a lot of lab draws. So we follow BNPs and have patients self-assess, so monitor their daily weights and hopefully are really in tune with their symptoms and how they feel when they're hypervolemic. So, I mean, yes, in a perfect world, I think an in-person volume assessment is ideal, but I think we do a pretty good job of using the data we have available to us to get a pretty accurate volume assessment over video.
Okay, so for those listening, what is hypervolemia and hypovolemia, and can you explain that?
Yeah, so these terms refer to volume status. So euvolemia is when our volume status is perfect. We're not retaining fluid. We're not dehydrated. Hypervolemia is when we are retaining fluid. So symptoms of hypervolemia may be swelling, increased shortness of breath when lying down. And then hypovolemia or dehydration is dehydration. So people may feel dizzy, thirsty, fatigued.
Right, perfect. Yeah. So you see patients in an outpatient clinic setting, and I'm glad that you highlighted that, how things transitioned from pre-pandemic to pandemic. Some argue we're still not really post-pandemic yet.
Sure.
But I know it's been a big issue for us at UCSF as far as telehealth goes because we don't have a lot of clinic space.
Yes.
And so I think in March there was something with CMS saying like we may not cover Medicare patients anymore for telehealth, which is a huge burden for patients who do live hours and hours away.
And it's expensive. It's so expensive to drive to UCSF, to park, to miss work to do this. Some patients are 6 hours away and have to spend the night.
Yeah. And of course, if they need that physical exam portion or there's some reason that they have to come in, it makes sense. But we have difficulty finding space and staff. And telehealth has really increased access to care for patients and appropriately. Fortunately, I think March 31st, it extended to September. So now our patients who need to see us can still see us via telehealth, but we don't know what September is going to bring.
Right.
That'll be interesting. The theme of this episode so far is that I don't know much about pulmonary hypertension, and you didn't know much about pulmonary hypertension.
I did not.
So can you explain what it is and how it differs from other types of hypertension?
Yeah. So yes, a lot of people, when I say that I work in pulmonary hypertension, they think hypertension. And I get a lot of weird looks.
And what is hypertension for those of us that don't know what that means?
Yeah, totally. So hypertension or systemic hypertension is high blood pressure in our systemic arteries, right? So like you put a blood pressure cuff on your arm, that's measuring whether you have high blood pressure in your body. Systemic hypertension differs from pulmonary hypertension in that pulmonary hypertension refers to high pressure in the lungs or in the pulmonary arteries. So blood circulates from our body into the right side of our heart, right atrium, right ventricle, and then from the right ventricle through the pulmonary artery. So you have the main pulmonary artery, which branches into the right and left pulmonary arteries, and then it's like a tree, right? There's smaller and smaller arteries. And so pulmonary hypertension refers to high pressure in this pulmonary artery system. And that increases afterload for the right ventricle. So it strains the right ventricle and can then cause right heart failure.
And the right ventricle is the right bottom chamber of the heart. So when we talk about cardiology and those aspects of it, you have two top chambers in your heart called the atria. There's a right and a left. And then you have two bottom chambers of the heart, the right ventricle and the left ventricle. So what are the different types of pulmonary hypertension and why is it important to differentiate them?
We have 5 main classes of pulmonary hypertension referred to as the WHO groups. WHO group 1 pulmonary hypertension refers to idiopathic pulmonary hypertension, so pulmonary hypertension that we've not identified a cause, genetic mutations that are associated with pulmonary hypertension, HIV-associated pulmonary hypertension, connective tissue disease-associated pulmonary hypertension, toxin-induced pulmonary hypertension, so certain diet pills like fen-phen, stimulants, methamphetamine-associated pulmonary hypertension is really big on the West Coast. Portopulmonary hypertension, so pulmonary hypertension that is a result of liver disease causing portal hypertension.
Which can be caused by alcohol. So,
yes, cirrhosis, hepatitis, yes. And then WHO group 2 pulmonary hypertension is pulmonary hypertension that is caused by left-sided heart disease, so HFpEF, HFrEF, so different kinds of left-sided heart failure or left-sided valve issues, so aortic or mitral valve disease can cause WHO group 2 pulmonary hypertension. WHO group 3 pulmonary hypertension is pulmonary hypertension due to underlying lung disease, so pulmonary hypertension is a vascular disease. If somebody has a parenchymal lung disease, so a disease of their lung tissue that then causes pulmonary hypertension, that would be a WHO group 3 pulmonary hypertension, so interstitial lung disease, severe COPD, sleep apnea associated pulmonary hypertension is WHO group 3. WHO group 4 pulmonary hypertension is CTEPH, so chronic thromboembolic pulmonary hypertension, the presence of chronic blood clots that then lead to pulmonary hypertension. People can have chronic blood clots that don't lead to pulmonary hypertension, so that's CTED, chronic thromboembolic pulmonary disease. But if it leads to pulmonary hypertension, that's CTEPH. And then WHO group 5 is just sort of other kinds of pulmonary hypertension that don't fit into one of the 4 previous categories. So sarcoidosis and sickle cell are 2 examples.
Okay. Yeah. What is the most common group that you see?
So the most common group in the United States is WHO group 2.
Okay.
But we don't have treatment for WHO group 2 pulmonary hypertension other than treating whatever kind of left-sided heart disease is causing that pulmonary hypertension. So typically WHO group 2 pulmonary hypertension is treated by advanced heart failure or by somebody's general cardiologist. But in our pulmonary hypertension program, WHO group 1 pulmonary hypertension is the largest group that we see.
So I know I asked why it's important to differentiate them, but it seems like it's because the treatments are different for each group. Is that correct?
Yes, exactly. So many patients are referred to us because they have signs of pulmonary hypertension on their echo. So that would be an elevated estimated pulmonary artery systolic pressure or right heart enlargement or right heart dysfunction. Those are things that indicate likely pulmonary hypertension. So patients are often referred to us at that point. And from there, we will typically obtain a right heart cath to confirm diagnosis. Okay. And along with that, we have sort of a standard protocol of testing that we do to help us evaluate all potential etiologies, to give us an idea of what the etiology is of this person's pulmonary hypertension, because that will determine treatment plan.
And I think when you were going through the different types, you kind of gave the common causes of pulmonary hypertension. Are there any risk factors? Anything that would put a patient or person more at risk for pulmonary hypertension?
Yeah, I mean, there are certain diseases that we know can cause pulmonary hypertension. So connective tissue disease, for example, we have a lot of patients that have scleroderma-associated pulmonary hypertension, a lot of patients that have methamphetamine-associated pulmonary hypertension. Of course, not everybody with scleroderma and not everybody who uses meth will then develop pulmonary hypertension, but certainly people with these chronic diseases or certain habits, interstitial lung disease, should be screened for pulmonary hypertension if they have symptoms that are consistent with pulmonary hypertension or certain findings on diagnostics that may indicate pulmonary hypertension.
What are some symptoms that patients might be exhibiting that would lead someone to screen them for pulmonary hypertension?
Well, it's unfortunate, but a lot of people, the symptoms of pulmonary hypertension are vague. So shortness of breath, fatigue, swelling sometimes, right? These are symptoms that can be present with lots of different disease processes.
Right.
So it can be really challenging, and pulmonary hypertension is a relatively rare disease. Unfortunately, people often start having symptoms of pulmonary hypertension, but it goes undiagnosed, sometimes for years, before they end up being referred to us for a diagnosis. If somebody has, one of these chronic diseases that are known to be associated with pulmonary hypertension and then develop shortness of breath, swelling, problems breathing when they lie down, these are signs of fluid retention that may indicate right heart failure, then that certainly is a reason to get an echo to screen for pulmonary hypertension. For a young, healthy person that has shortness of breath, screening for pulmonary hypertension is probably not top of the differential. Certainly an echo maybe, and that would show signs of pulmonary hypertension, but a young person who's healthy otherwise, who has shortness of breath, pulmonary hypertension wouldn't be top.
So is it fair to say that this is more of an incidental finding? Like someone's having like shortness of breath, or to me, that just feels like heart failure symptoms. Like the things that you're talking about feel like, oh, this is a patient with heart failure. Is it like incidental? Like you do an echo and then you've got all these like elevated right-sided pressure and like, would you see like the right ventricle stretched out or the right atrium stretched out, that kind of thing?
Yeah, totally. I don't know if it's incidental, but if somebody has shortness of breath or signs of heart failure, usually an echo is indicated, and part of reviewing the echo is reviewing the echo for signs of pulmonary hypertension.
Okay. And what are the signs on an echo?
Yeah. So elevated estimated pulmonary artery pressure, and then any sort of right-sided dysfunction. So enlarged right ventricle or right ventricular dysfunction. The right atrium also may be enlarged.
Okay.
Yeah. Totally.
Because I'm used to looking at left side, especially for the left atrium with AFib, because if I see that, I'm like, haha, there's either a valve issue or you have an arrhythmia.
Yes.
And likely. And so when I see the right, like I'm like, oh, there's some pulmonary issue going on. That's just like the nursing clinical pearl. It's like you just quickly think, okay, I see that. And then you move on because, like you said, pulmonary hypertension is pretty rare, and I don't know much about it outside of the fact that I had a friend who's very healthy, young, and she told me that she was diagnosed with pulmonary hypertension. And this was before I worked at UCSF or even knew really about it, which it's kind of interesting to like be in cardiology and then not really know about this, even though it crosses into, lungs and not just heart, but it's how the body works, which is fascinating. But one of the things that she asked me, and I would love to know your take on it, like, because I don't know what class it is. I don't know anything. Because I was like, I'm sorry, I really don't know. You're going to have to like, just really talk to the experts, because I don't even know what questions to ask. Now I do. But what would you say for someone that's young that has something like that? Can people like still exercise and run and do all the things that they can if they're not symptomatic?
Well, it really depends on how severe their pulmonary hypertension is, how severe their right heart failure is. Because this is not a common disease, it's usually in like later stages that people are diagnosed. So once they really develop right heart failure, often people present because they go to the emergency room with heart failure, right? And they're admitted, and then an echo suggests pulmonary hypertension, and then a diagnosis is made. They're in acute right heart failure at that point. But the good thing is that medications we have, once we reduce the pulmonary artery pressure and reduce right ventricular afterload, is that right ventricle can actually recover.
Really? Okay.
So in terms of, can somebody with pulmonary hypertension, how much exercise can they do? Probably similar to your patients. We always advise, listen to your body. Don't push yourself too hard. Start slow and build up over time. But especially once, if we're able to adequately treat and control pressures and get right ventricular recovery, somebody who has normal right ventricular function can probably, they still should be cautious, can certainly engage in exercise. Yeah.
I know that's one of the things that shifted in my practice from Florida to California. It's here like people are just chomping at the bit to get back into being active and hiking and running and I'm like, okay, listen to your body. And I'm like, and then I give them the eye, like, I know you're not really going to, but we really need to.
Totally.
How is pulmonary hypertension diagnosed? And is there a gold standard? Are there different ways to diagnose it?
Yeah, good question. So most people have an echo first. So when somebody has shortness of breath or signs of heart failure, typically an echo is the first diagnostic. And if an echo suggests pulmonary hypertension, the gold standard is a right heart cath.
Okay.
A right heart cath is a very quick procedure. It's done in the cath lab. A catheter is advanced through the vein, typically accesses through the arm, but can also be through the neck or the groin. And this catheter, which is a wire, is advanced through the vein into the right atrium. So we take direct pressure measurements in the right atrium, the right ventricle. The catheter is then advanced into the pulmonary artery, where we get a direct pressure measurement in the pulmonary artery. And then we do what's called a wedge pressure, where there's a small balloon that's inflated just temporarily in the pulmonary artery, and we are able to get an indirect pressure measurement of the left side of the heart, so this should be equivalent to an LVEDP.
Oh, okay. Great.
Yeah. So, and then we also measure a cardiac output and then can calculate pulmonary vascular resistance. So essentially, gold standard is a right heart cath, and you can get a lot of information about the severity of pulmonary hypertension, but also the etiology of pulmonary hypertension. So we can see, is this precapillary, postcapillary? Sometimes it's combined pre and postcapillary.
And what does that mean?
Yeah. So where is the pulmonary hypertension originating from the left heart or from before the left heart?
Okay.
Yes. And there's also some other tests we can do in the cath lab, like an exercise right heart cath, where we literally have patients on their back, pedal on a bike, and repeat measurements while they're exercising. That's the exercise right heart cath specifically identifies WHO group 2 pulmonary hypertension, or HFpEF.
Which is heart failure with preserved ejection fraction, which means a preserved ejection fraction, a normal ejection fraction, which is the number that tells us loosely how well the heart pump is functioning, is 55% or higher. So that would be a preserved ejection fraction. Then less than 55%, then there's a lot of different ways we can classify it, and that's very detailed for what we're talking about today, but that's just what HFpEF or HFrEF means, reduced ejection fraction, and there's other little things you can slip in there that mean different things, but that kind of tells us what number we're looking at for how effective the heart is at pumping blood.
Right. So impaired relaxation. Yes.
Exactly.
Yes.
I'm sure patients find that experience very interesting, to be awake and exercising. And it's very different than the kind of catheter procedures that my specialty does, where most all of the time they're very comfy and snoozing or completely snoozing.
So, I think our patients would prefer to be snoozing most of the time. But
now, sometimes when they do right heart caths, they also do left heart caths. Is that correct?
Yes.
Okay.
Yeah.
That is more related to interventional cardiology, where we're looking at the coronary arteries and if there are any blockages in there, correct?
Yes, exactly.
And why would you couple those two together?
So in patients that are diagnosed with pulmonary hypertension, or we have a high suspicion for pulmonary hypertension, we also should rule out coronary artery disease, at least in those who are at risk. And the reason is that coronary artery disease can cause left-sided heart failure with preserved ejection fraction or with reduced ejection fraction, but that can certainly contribute to pulmonary hypertension. So often we'll get a stress test initially to rule out ischemia, right? Reduced blood flow to the heart. But if we have a high suspicion for coronary artery disease, or in someone who's already has established coronary artery disease, we'll often just get a left heart cath at the same time we're doing a right heart cath.
Because you're already there.
We're already there. It's an additional access point. So with the left heart cath, the wire goes through the artery to lead into literally the left side of the heart, and the coronary arteries. So it's an additional puncture, but the patient is there and it's relatively easy.
Yeah, great. Get both things done at once.
Yeah.
So when the patient is then diagnosed and you classify what type of pulmonary hypertension that is, what are the next steps?
So once we identify the etiology of pulmonary hypertension, then of course we ideally would initiate treatment. We have medications. We have most of the medications we have available are pulmonary vasodilators. So we have three main classes of pulmonary vasodilators that work through different mechanisms to vasodilate the pulmonary artery. So we're reducing right ventricular afterload.
Okay. What does vasodilate mean?
So to dilate the pulmonary artery.
Okay. So you're making
it bigger to reduce the pressure inside.
Okay, got it.
And reduce strain on the right heart.
Perfect. That makes sense.
Yeah. And hopefully allow the right heart then to recover.
Mm-hmm.
So shrink back to a normal size, to be stronger over time.
And for nurses that are listening, what are some of those, what are the names of some of those medicines?
Sure. So we have the first class of medications, the PDE5 inhibitors. We have sildenafil and tadalafil. And then we have Adempas, which we use frequently in CTEPH patients. And then we have a second class of medications that includes ambrisentan and macitentan. And then in this third prostacyclin pathway, we have oral, inhaled, and infusion. So both intravenous and subcutaneous infusion options. So Uptravi, Orenitram, and Tyvaso is an inhaled treprostinil. And then the infusion medications are Remodulin and Velitri.
Okay. I have seen a few of those on my patients list before. Yeah. So, pulmonary hypertension. Okay.
Yeah. And then we actually have one new medication. It's a novel medication. It was FDA approved about a year ago. And it has a completely different mechanism. It's not a pulmonary vasodilator. It has an anti-proliferative pathway. It's called sotatercept, or the brand name is Winrevair. And this is an injection medication. So patients self-inject every 3 weeks. And this is approved only for WHO Group 1 pulmonary hypertension. And we actually don't use it in all WHO Group 1 pulmonary hypertension patients, but in quite a lot.
Wow. So really getting the diagnosis and then understanding what the cause or the etiology is and what WHO group they fall in really drives treatment.
It does, yes. So patients also might have combined etiologies. So they may have like WHO Group 1 pulmonary hypertension with contribution from WHO Group 3. And we actually see this quite frequently. So somebody may have Scleroderma-associated pulmonary hypertension, which is WHO Group 1. And then they may also have, for example, Scleroderma-associated interstitial lung disease, which is then a WHO Group 3. And so we have to be mindful when we're using these medications that we are targeting the correct kind of pulmonary hypertension. Certain medications used for one group of pulmonary hypertension may actually be harmful if used for a different etiology of pulmonary hypertension. So we have to be very mindful of how we're treating patients that have combined etiologies.
Then
if that makes sense.
Yeah, it makes perfect sense, which is why it is such a great subspecialty, because these patients really need that care, because electrophysiology is not going to know anything. And I'm sure that's way past what like a general cardiology, either a physician or a nurse practitioner, really knows. I'm sure they know how to treat pulmonary hypertension, but not to that detail and to be able to follow the patient that well.
There's a lot of nuance. Yeah, as there is in all of our practice, but yes.
Yeah, absolutely. Yes. Which is why it's so important. I had posted a reel on Instagram at one point because I had a patient who was at first a little bit irritated that I wouldn't refill like a diabetes medication, and I don't specialize in it, nor do I follow it, and it wouldn't be safe. Well, yes, I have the resources and the ability. I know what medicine it is. I could prescribe it, but I am not monitoring it. I don't know it, and I don't know the nuances of it.
Totally.
And so I like tell patients, you really need to go to your specialist that knows that and follows it and can write for that, because would you feel comfortable refilling dofetilide?
Never. Yeah.
Like, just because there's so many different things that you have to look for and know. And so that it's not that providers don't want to refill medications and make things convenient for patients. It's that a lot of medications need to be monitored. And like you said, if you're using a medication for the one type of pulmonary hypertension and they actually have a different type, it could cause harm, and you don't want to do that. None of us want to cause harm.
No, we don't.
How has treatment for pulmonary hypertension evolved?
It's evolved a lot, actually, over the last 15 plus years. I mean, I think I mentioned, but most recently, about a year ago, the FDA approved sotatercept, which is a novel medication, the first in its class. So there's been a lot of excitement around that. We've actually just anecdotally, we've had a lot of patients who have had really remarkable improvement in their symptoms and also improvement in right ventricular function since starting this medication. I mean, really less than a year ago. So anecdotally, it's been really significant for a lot of our patients.
What do advanced therapies like these targeted medications play in treatment? And is there an option for transplant?
Yeah, so when we refer to advanced therapies in pulmonary hypertension, we're referring to infusion therapy. So that would be the Velitri and Remodulin, which I mentioned earlier. Velitri is infused intravenously, and Remodulin can be infused either intravenously or subcutaneously. But these are 24/7 continuous medications that patients are initiated on in the hospital and then they go home with. They're connected to a pump. They're responsible for changing their cartridges and changing their site if they have a subcutaneous infusion. And they're really high risk. So if interrupted, Velitri has a half-life of several minutes. Remodulin has a half-life of several hours, so it's a little bit safer compared to Velitri. But if interrupted, the patient is at risk for rebound pulmonary hypertension. So developing really high pulmonary artery pressures very quickly can cause acute right heart failure. The patient can decompensate very quickly. So it's a really high-risk medication. And then if somebody is managed on infusion therapy and still has progressive pulmonary hypertension, because pulmonary hypertension is a progressive disease, unfortunately, then yes, lung transplant is an option. They, of course, have to be referred to lung transplant and go through an evaluation process, but that is sort of the ultimate treatment that we have at this point for pulmonary hypertension.
When you say it's progressive, I know it likely depends on how effective the treatment is for the patient and other things that are happening. But in a typical average patient, how do you see that timeline?
Patients ask us this all the time, of course, right? They want to know, they want to have a prognosis, but unfortunately we don't have a lot of data, and it's really hard. It just depends. It's very individualized. It really depends on how each person responds to therapy. And also, if they have an underlying disease process that's contributing to their pulmonary hypertension, how well treated is that process?
Yeah.
So it's so challenging to predict. I mean, we do have patients that have had pulmonary hypertension for decades and have been on infusion therapy for, also decades. And we have others who are diagnosed and then have progressing disease within years or months even. I mean, it's really, really challenging to predict.
Yeah, I tell patients, they're like, if I have an ablation, will I get AFib again? And I'm like, I don't have a crystal ball, but once you have AFib, you are always having AFib.
Yeah.
Maybe not actively, but
right.
you just have AFib.
Right.
So
totally.
If another nurse or provider that doesn't specialize in pulmonary hypertension is seeing a patient that has pulmonary hypertension, or they get admitted to the hospital and you're like me, a brand new nurse on med surg, and someone has pulmonary hypertension, are there any things that you should be aware of, or things that you should assess, or kind of like be like, oh, this is something that is worsening?
Yeah, we run into that all the time, right? Like patients with pulmonary hypertension don't only have pulmonary hypertension. It's really important, I think, first and foremost, to be aware of volume status.
Okay.
I think a lot of patients go to the emergency room and they're a little hypotensive and they get lots of fluid. Well, somebody with pulmonary hypertension will then very quickly become hypervolemic.
Right.
So volume status is really important. It's also really important, of course, in thinking about surgical risk and making sure if somebody needs surgery that they're at a hospital that has maybe cardiac anesthesia, and a cardiology team is familiar with pulmonary hypertension so that they can help manage any sort of complications that may happen. But if possible, if somebody with pulmonary hypertension is really sick, even if it's not related to their pulmonary hypertension, it's usually ideal that they are transferred to a center that has a pulmonary hypertension program.
Okay, that makes perfect sense. So kind of dovetailing into that, because, we're a center, but pulmonary hypertension does require a multidisciplinary approach.
Yeah.
So can you talk about the team effort involved in caring for these patients?
Yeah. So, of course, our physician team, we have both cardiologists and pulmonologists. And our pulmonologists tend to treat all etiologies of pulmonary hypertension, but they tend to focus on the WHO Group 3 pulmonary hypertension. So pulmonary hypertension related to underlying lung disease. We have a nurse practitioner team. We have a nurse coordinator, our patient care coordinators who do all of the coordination and scheduling and authorizations for testing and appointments. We have our pharmacy team who they're amazing because almost all of the medications we prescribe are specialty medications and they all require prior authorizations that are often denied. So it's a long process. So our pharmacy team is really important.
So is it the cardiac pharmacy team, or do you get a specialized pulmonary hypertension?
It's part of the cardiology department.
Okay.
Yes, maybe one day.
Okay. Yeah,
not as of now.
I just want to also give them mad kudos because I love having a cardiac pharmacy team for some of my antiarrhythmics and when things are complicated and there's so many,
yes,
I'm dealing with your pulmonary hypertension meds and the EP meds and then other meds. And I'm like, can these all go together? You just ask them and they
do it all.
Oh, they do it all. They're amazing.
Our team is unique in that we have a dedicated social worker. So our social worker does things like supports transportation to appointments, but also our social worker performs psychosocial evaluations for patients who we are considering advanced therapies in. So lung transplant, but also infusion therapy. If we initiate infusion therapy in a high-risk patient, then we're really introducing more harm than potential benefit. So it's really important that we do this psychosocial evaluation to really ensure treatment success. And then if we identify, and as part of this psychosocial evaluation, we identify risks that we deem too great to safely initiate therapy, our social worker can work with that patient to help modify their risks so that they're in a more optimized position to then initiate therapy. And I also think that it's really important that we have this psychosocial evaluation because it's a way to provide equity of care to patients, especially since we have such a large methamphetamine-associated pulmonary hypertension population. I think we want to make sure, that we're providing the same standard of care to every patient, and having a standardized approach is a way to hopefully do that.
Absolutely. So that kind of just leads right into, how do you approach mental health and emotional well-being of pulmonary hypertension patients? It sounds like with the social worker, there's like a touch there, but
yeah, it's so challenging. Our social worker certainly can provide some counseling, but also helps connect patients to the resources in their community. But it's really challenging because, as you probably know, there's just a lack of resources out there. There's a lack of resources. Again, we have a really large methamphetamine-associated PH population, and we don't have great treatment for methamphetamine addiction. So it's really, really hard, but we try to approach patients with a non-judgmental approach, meet people where they're at, frequent visits, and continue conversations about all of these things.
It's absolutely super important. And it's interesting. I went on a bike ride this morning, and I was thinking about future content and an episode about patients as autonomous beings who can make their own decisions. Patients, I'm speaking of you and me too, because we're patients, we're consumers of healthcare. And Dr. Shaw and I last week had a patient, and we saw a new patient, and you could tell that they were beating around the bush about how much alcohol they drank. No judgment from us. One, we die once. We get to live this life, and it's our life, and we get to make those choices and decisions.
Totally.
And I want to look into and talk to other people and read more books and some papers on how do we approach this with our patients so that they can just be honest and not feel shame for the choices that they make. Because it's not that I don't care about the choices that they make. I care very much about my patients' well-being, but they get to do whatever they want with their life. As long as I know what's going on with them, then I can provide the best evidence for whatever's going on in their life and how I can support them with the choices that they want to make. And I feel like it's such a thing that is needed because there's so much shame around choices, but there shouldn't be.
I so agree. I could not agree more. Yeah. And very relevant also for our pulmonary hypertension population. I agree. As a provider, it's our place to provide information and evidence and risks of different decisions. And then people get to make whatever decision is best for them. Yeah. And we're not them. We haven't lived their life. Yeah. I totally agree.
Right. As long as we know what is happening and, I'm not prescribing a medication that's going to be dangerous with something else that you're choosing in your life, which is fine. You can choose that for your life. I'm not here to tell anyone that they're doing wrong. Like, I mean, yeah, maybe that's not the best choice for your heart health. It's your choice. Yeah. And I think as healthcare providers, we can start to shift those ideas and like social conditioning so that patients can just be honest and free of that shame. And just, we can provide the best care possible. And I know that was like a segue off of that, but it was something that I felt really strongly about today. Like,
yes, I agree.
Something to talk about.
Yes. And yes, I so agree. And that's very relevant in our, methamphetamine associated PH population. We offer the same oral therapy, although I will say that not all pulmonary hypertension providers do. I think most at UCSF do, because there's no harm, right, to give somebody who's actively using meth oral medication to treat their pulmonary hypertension. But there are providers out there who feel that if somebody is going to continue using a toxin that's causing their pulmonary hypertension, like, why treat with medication?
Yeah.
To me, morally and ethically, that's wrong. I think we have this treatment and we should offer it.
Right.
Yes. But in somebody who's actively using meth, we don't offer infusion therapy because the risk is too great. It outweighs potential benefit. But once somebody is able to demonstrate that sobriety over a 6-month or so period, then it's definitely something we offer.
You're right. Treatment should not be withheld from patients if it's safe to treat them, regardless of their decisions.
Totally.
And I know it's a big consideration for us when we're implanting ICDs in patients. So we do have to really think about, like, if patients are taking stimulants and they're going to continue to do so, or they're not going to follow up, or they're at risk for infection, or because if they
of course
have tachycardia and then they just get multiple shocks. And so it's something that just really needs to be discussed. And it's not that we withhold defibrillator implants per se for lifestyle choices, but it's a discussion.
It's a discussion, and it's a risk versus potential benefit conversation.
Absolutely. With that being said, and since we're kind of talking about the whole person right now, what lifestyle modifications would you recommend for pulmonary hypertension patients to improve their quality of life?
Well, like we discussed earlier, volume management is a really big issue. So limiting fluid, limiting sodium, right? Because fluid follows salt. And then daily weights, so that if somebody is starting to retain fluid, we can identify it early and treat it using diuretics early before it becomes a big issue that requires admission.
Do you have a standard salt intake or a fluid restriction amount, or do you titrate it to the patient on their symptoms and how they're feeling?
Yeah, well, for patients that are really struggling, we say usually maximum of 2 grams sodium per day and maximum of 1.5 to 2 liters of fluid from all sources. But that can be really challenging. This is a balance, right? This is a balance. Most patients are on diuretics. It's really about, the balance that is working for each individual person. I mean, that's sort of what we strive for, but I don't know how realistic that is, for every person.
So with with the diuretics and then weighing themselves, and then you can adjust their, like, the salt and the volume or the fluid.
Totally. Yeah. I mean, the goal is to get to sort of this steady state, right? Where patients are on a stable dose of diuretic and they're probably taking in a similar amount of fluid and sodium on a daily basis, so that they're able to just live their life without having much fluid retention. But of course,
life happens.
And we need to make adjustments. And
yeah. So outside of that, any other lifestyle modifications?
Outside of that, just sort of what is healthy for all of us, right? Yeah. So eating healthy foods and moving our body, sleeping well, low stress. Easier said than done. Absolutely.
How can patients and families best advocate for themselves?
Yeah, that is an excellent question. I think this probably is not specific to pulmonary hypertension, but just generally in healthcare. I think it's really important to know what's happening in your health, right? And go to your provider, have your appointment, ask questions, ask enough questions so that you understand the treatment and you understand the reason for the treatment. And if something doesn't feel right, to keep asking until you get an answer that's satisfactory, and keep escalating. It can be so hard to advocate, and in this medical environment where everyone is short-staffed, appointments are scheduling out months. It can be really hard, but it's really important. Also bringing family or friends, right, to listen and provide support can also go a long ways.
Yeah, I think bringing someone with you, because I think I've said this before, but especially when you get a new diagnosis of something,
so overwhelming.
Like you're drinking from a fire hose.
Totally. Totally.
And then you're going to miss things. You're not going to remember it because you're dealing, like there's just so much going on, and you bring someone else, they're catching some of the things.
And that's why I like telehealth, right? Because you can have this initial appointment, go home, think about it, write your 5,000 follow-up questions, and then have a video visit a week or two later to review and go through all of those things.
Yeah. And that's one of the greatest things about being an APP as well, or a nurse practitioner, advanced practice provider, is that sometimes the physicians have shorter visits and they are much faster and they have to address things really quickly. A patient can come and have a visit with you or me, and we can really then answer those questions, and we can spend a lot more time. Like my follow-up visits are 30 minutes. And so I can, after that initial I just drank from the fire hose and I don't know, there's so many options with atrial fibrillation, I can sit down and go through them again with them and then answer all their questions. Totally. So that's where this team-based approach with us working with physicians and even our nurses, sometimes they'll be on the phone for 45 minutes with somebody answering questions. But don't be afraid to ask, because that's really why we're here, to help patients understand so that they can make informed decisions about their care.
Totally.
What is one thing that you wish more people understood about living with pulmonary hypertension?
The challenging things, I guess, is also a beneficial thing for some patients, but pulmonary hypertension is invisible, right? And this is something we hear a lot, but it can be a really challenging thing for a younger person who looks normal, right? But can't keep up when they go on a walk with friends, or they can't keep up at work. And I think there's patients often feel stigmatized because they can't do the same things as those around them. And people don't believe that they're truly sick because they look normal.
Yeah.
And that can be really hard. On the flip side, some people, of course, that's a benefit also to some, that their disease is not external. And so once, sometimes people end up requiring supplemental oxygen. Or if somebody ends up needing infusion therapy, now they do have something external, right? That people identify, and it sort of makes them look sick in a sense. That can also be really challenging. People with pulmonary hypertension may look totally normal, but they really do have physical limitations. That can be really challenging.
So how can listeners connect with resources and learn more about pulmonary hypertension?
The Pulmonary Hypertension Association has an excellent website.
Awesome.
With lots of information.
Okay. Yeah. Great. So we'll link that in the show notes, of course.
Wonderful.
And any other things that you have that would be useful, we'll put those in the show notes as well. I know that what I'm about to say, we didn't discuss. Our listeners, I think they should hear about this, because I think that, you're a brilliant colleague and friend of mine, and we went through a leadership program at UCSF together, and you did a project, which I think was fascinating. And I would love just for you to just say a little bit about that, because of the nurses and patients that are even listening, to know that there are brilliant people out there thinking of ways to give more access to care. And I love that about your project. So
thanks. Sure. So I did a project. So we use something called a 6-minute walk test, which is literally how far can somebody walk in 6 minutes. It's distance measured, and it's an endpoint that's used in a lot of studies for pulmonary hypertension medications. And it's something that we monitor in patients over time. And if it's just another objective measure, right? So if we notice that the 6-minute walk test is declining, sometimes symptoms decline so slowly that somebody may not recognize that in themselves. But if we see that 6-minute walk test is declining, that may indicate to us that something is changing. So we used to collect 6-minute walk tests with every visit, which was about every 3 months for in-person visits pre-pandemic. But then once we moved to a largely telehealth model, we are now no longer collecting this data point. And a 6-minute walk test is also important because we use it in a mortality risk calculator. So it's another thing that informs our treatment decision and whether to escalate therapy. So my project was comparing clinic-administered 6-minute walk tests with self-administered 6-minute walk tests, right? So now that we have telehealth, patients can do their own 6-minute walk tests at home. We'd have a lot more data to help inform treatment. And so reviewing the literature, there were a lot of cohort studies comparing clinic-administered with self-administered 6-minute walk tests using various different methods for monitoring a self-administered 6-minute walk test. The takeaway is that a self-administered walk test can certainly be as accurate to clinic-administered 6-minute walk test. I think before we can implement a self-administered 6-minute walk test, we have to put a lot more thought into exactly how it will be monitored. Of course, these require some sort of technology that not all people have, though most people probably have a smartphone. In this research, I saw an abstract that Stanford Pulmonary Hypertension Program recently did their own study comparing clinic-administered 6-minute walk tests with self-administered 6-minute walk tests, specifically in their pulmonary hypertension population. So I'm really excited to see that full study, and I'm hopeful that once we have their study and their results and we can see their methods, hopefully it's something we can implement in our programs. We already have their validated tool, but we'll see.
Yeah, that would be great because increasing access to care for everyone is so important.
Totally. Yeah.
Well, Emily, thank you so very much for chatting with me today and for increasing my knowledge on pulmonary hypertension. I really appreciate it.
Thank you for having me. This was fun.
It's my pleasure. Take care.
Thanks.
Thanks for tuning in to this episode of In the Loop with Naja Vlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.